Good afternoon. My name is Saya Wen, and this presentation is on the examination of anxiety in children and adolescents and effective treatment modalities. And this is a presentation as part of a requirement for my graduate program, Department of Psychology um, at Liberty University. So to begin with, this is a table of contents. First, we'll be talking about the introduction. Next, I'll be talking about current research, followed by gaps and limitations, my research proposal, conclusion, and finally, my references. So as I mentioned, introduction. This presentation is an overview of the current literature and proposal of research. So current research. Adolescence is defined as a transitional period between childhood and adulthood. Adolescents account for approximately 18% of the world population, with 1.2 billion of adolescents being between the ages of 10 and 19, and that's from Morgado et al. 2020. Adolescent developmental period is one of the biggest and largest psychological changes within an individual's lifespan, as a broad range of cognitive, physical, and social and environmental developments may occur during this time period. In addition, children typically leave this developmental period with a deeper understanding of themselves, higher quality of life, and stronger relationships. And that is from Yang et al. Adolescents experience faster physiological growth, but slower psychological growth in adolescence, which can lead to low rates of psychological maturity. Adolescents are exposed to stressors such as academics and things that go on in day-to-day life, which can be stress with the friend group, parents splitting, cyberbullying, or just not fitting in at school. Adolescence is also a vital period in mental health, and it is the onset for several mental health disorders. On average, 16% of adolescents have been diagnosed with a mental health disorder, and that's also from Morgado et al. Forming social relationships outside of the family unit is critical in adolescent development. The formation of these relationships, unfortunately, were compromised as a result of the pandemic. When COVID-19 shut us down, unfortunately, there was a lot of social distancing going on, and children were not able to naturally make friends as they once had been. Next is anxiety. Anxiety is defined as a manner in which the brain responds to a stimuli or danger that an individual will typically attempt to avoid. Anxiety can interfere with overall functioning and become more severe or persistent as time goes on. Physical symptoms of anxiety include disturbance in sleep, restlessness, chronic headaches, muscle tension, and gastrointestinal distress concerns. Anxiety disorders are classified using the Diagnostic Statistical Manual, 5th edition, DSM-5. Anxiety disorder includes generalized anxiety, separation anxiety, social anxiety, selective mutism, panic disorder, specific phobia. Each of these orders must meet a specific criteria in order to be diagnosed. General anxiety disorder and social anxiety disorder are often examined together as they have a common comorbidity rate. I apologize. Similar risk factors and respond similarly to treatment, and that is from Strawn et al. And next, I will go into the topic of the disorders that I just named in deeper light. So, generalized anxiety disorder is the excessive anxiety lasting at least 6 months regarding several situations or activities. So, this could be from being anxious in a social situation to also being anxious when at school or what have you, or at home or about a certain issue. Separation anxiety is excessive fear or anxiety surrounding the separation from a parent or loved one. This sometimes occurs when children have been separated from their parent, whether that is a removal from the home or if the parent was sick for an extended time of period and unfortunately the child and their loved one were separated, which can be very, very sad. So social anxiety disorder is typically has an onset during adolescence, and it occurs around certain social situations which can be characterized by fear and heightened levels of distress and impairment. So sometimes when I think of social anxiety, I think about going into a large group of people and you only know maybe one or two, and then you just becoming very, very heightened, afraid, and honestly in distress and just wanting to leave. Selective mutism is characterized by an unwillingness to speak in a social environment when the expectation is to speak. Um, so an example, when I think of this, is a student not speaking at home, but speaking at school or vice versa. Um, I have had recent work in this where the child did not speak at home or at school, but only spoke to one sibling, which occurred closed doors. Um, and she did not mention speaking to the other sibling, and it's been like a really private matter between the two of them, just out of fear of it being disrupted. Panic disorder is characterized by recurrent, unexpected panic attacks, and it is persistently concerning or persistently being concerned or worried about having more panic attacks. Um, so the individual changes his or her behavior in a maladaptive way out of fear of these attacks. So, for example, they avoid exercising or avoid going into unfamiliar locations or avoid going into environments which they feel like might cause them more distress. Next is specific phobias. The reaction in specific phobias is always immediately, and it's induced by fear to a degree that is not persistent or would be out of proportion for an other like the actual posed risk or how someone else might react to it. And there's various types of specific phobias. Um, so there's animal and natural environment, blood injections, situational. Um, an example I think of when it comes to this is a fear of clowns or a fear of trichotillomania, which is like small holes. So next is more current research. Anxiety disorder begins typically during childhood and adolescence, and it is one of the most common disorders lasting across an individual's lifespan. Excuse me. In 2016, the National Survey for Children's Health reported that in the United States, 4.4 million, which is 7.1% of children between the ages of 3 and 17 had at one point experienced anxiety. That number is extremely alarming. And 4.5 had concurrent behavioral problems, and 1.9 had concurrent symptoms of depression. And that was from Garcia and O'Neill, 2021. In addition, it is estimated that 1 in 3 adolescents ages 13 to 18 will have anxiety disorder. Today, 38% of children and adolescents have symptoms of anxiety. School plays an important role in the lives of children and adolescents, as it is where children mostly spend, honestly, the majority of their lives. And when you think about it, most kids enter school around kindergarten, which is age 5, and do not leave until 12th grade, which is typically around 18. So give or take 12 or 13 years. Um, Anxiety can affect the way in which students interact. They may be withdrawn, avoid social situations, have greater difficulty with academics, and also have poor attendance, in addition to experiencing peer victimization. And that is from McDonald et al. 2020. Anxiety disorder, if left untreated, may lead to short and long-term effects, chronic effect of development, and often serves as a predecessor to anxiety and depression in adulthood. That's from Strawn et al. In addition, children with anxiety are at a higher risk of a concurrent mood disorder, disruptive behavior, suicidal behavior, substance abuse, underachievement in education, higher risk for unemployment, poor academic performance, teen pregnancy, and poor overall health, and possibly economic difficulties later in adulthood. Anxiety is also a strong predictor for future development of other mental health disorders. Anxiety is one of the most common disorders within the United States population. That's from Nelson et al. Rates of anxiety are higher typically in women than in men. Roughly 40% of women will have anxiety disorder at some point during their life. And then the study that Nelson et al. Conducted, 23% of the women were diagnosed with anxiety disorder. And then anxiety disorder often goes untreated in these patients as they are hesitant to discuss their distress or experiences that may relate back to anxiety, depression, or other related mental health causes. Children who have parents with anxiety are 4 times more likely to have symptoms of clinical anxiety and 2 times more likely to have symptoms of clinical depression. And that's from Rainey et al. Children who have parents with higher levels of anxiety tend to have difficulty with emotional regulation and behavioral avoidance. The amount in which children can rely on their parents to provide support has implications for the manner in which adolescents are able to adjust during the critical period of adolescence. Research indicates that parents are a vital role in the psychosocial adjustment of youth well into late adolescence and adulthood. And that's from Simpson et al. Adolescent parent communication has also become an indicator of the quality of the parent-child relationship. So if the communication is very positive, that tends to mean that the overall nature of the relationship will be positive. But if the child views it as being a negative communication, then the relationship would always also be viewed as negative. Higher quality of adolescent parent communication has also been associated with greater psychosocial functioning, fewer internalizing of symptoms in adolescence, reduced emotional distress, and adjustment issues. And that's also by Simpson et al. Adolescents with anxiety had an increased risk of binge drinking, and dependency on alcohol, whereas worry was associated with lower risk. Adolescents with social anxiety and panic disorder were predicted to have alcohol dependency in early adulthood. However, it was not associated with alcohol abuse, and that was Dyer et al. 2019. There are also concerns regarding the worsening of symptoms in children and adolescents' mental health post-pandemic, as I mentioned before, as adolescence is a crucial part of a child's life, and disorders such as depression and anxiety can impact health and functioning into adulthood. And the pandemic possibly affected this, as I mentioned, by the social isolation. It has been associated with mental health, the pandemic affected factors such as mental health, routines, finances, and the inability to socialize with others. So next is treatment modalities. One of the top priorities within current research on global mental health concerns is the developing of non-stigmatizing and cause-effective treatment methods for depression and anxiety. An estimate of 25% of youth receive professional help. This may be associated with lack of knowledge, accessibility of mental health services, limited amount of providers around, the cost of therapy. In addition, adolescents may be reluctant to receive help due to the perceived stigma, current concerns for privacy and confidentiality, concerns for cost associated with treatment, transportation, and they feel that counseling is a huge self-reliance, and that is from starting to occur 2019, at all 2019. I apologize. And treatment for anxiety is estimated to cost $42 billion a year, and that's from Garcia and O'Neill, 2021. So next we will go into treatment modalities. So these are the most common treatment modalities that I found in current research. Cognitive behavioral therapy is a psychosocial intervention that aims to mitigate symptoms of several mental health disorders. This is Paris et al. 2021. Online interventions can be completed in various ways, from the therapist using the program in session with clients. The therapist can also use a program alongside face-to-face sessions, and it can be a self-guided program completed independent of a therapist. Next is internet-based CBT, which is also referred to as iCBT. It has been created to reduce the gap created by barriers to CBT, such as financial, transportation, things along that nature. It has increased accessibility and decreased cost in comparison to the traditional CBT, as I mentioned. iCBT can also be completed weekly and can be utilized as a self-paced or guided by a therapist. So similar to both the cognitive and, of course, the online intervention. Next is psychoeducational programs. Psychoeducational programs contain components of CBT, group, and education. It aims to provide the patient and their families with basic knowledge about elements of their illness or diagnosis so that they can work together with the professionals to obtain a better outcome. And that's from Morago et al. 2020. School-based interventions are designed to be utilized in a school setting, of course, to improve the health and overall being of students. The aim is to reduce or prevent mental health concerns and problem behaviors such as depression, social anxiety, drug or alcohol use, bullying, and aggression. And that's from McDonald et al. 2022. Music therapy is a treatment method that is non-pharmacological treatment. It has shown to be beneficial in improving symptoms of anxiety and depression in both children and adolescents. And that's from Belsic et al. 2022. So to dive deeper into CBT. So CBT is a well-used intervention for treating children and adolescents with anxiety disorder. It has been seen as one of the best treatment modalities for treating youth with anxiety, and that's from Rowe et al. 2023. CBT has been proven to demonstrate effectiveness. Previous longitudinal research suggests that 48% of participants in the Paris et al. Study relapsed during the transition into adulthood, and 30% remained chronically ill throughout their life. So those that did not receive the treatment remained ill. However, there are also several barriers, as I mentioned before, such as lack of resources, financial costs, maybe not having access to the treatment in the geographical area, lack of diagnosis, and poor recognition of symptoms of anxiety in youth. And as mentioned, one of the best ways of overcoming this is online intervention. as it can be provided on a large scale with limited cost. So online, as I mentioned just now, it is one of the ways to overcome the barrier to treatment, as it can be provided on the larger scale in comparison to traditional CBT, which is done in your normal office, face-to-face, or telehealth, whereas an online intervention can be done all over the world, and the counselor and the client can work on it together, or the client can go off and do it on their own and come back to the counselor if any concerns arise, or they can discuss it together. It also alleviates the pressure of finding adequate transportation. This can be completed in various formats, as I mentioned before, which is face-to-face, self-guided, and completed independently. Internet-based CBT, ICBT, it can easily be altered to an online format. CBT, sorry. CBT can easily be altered into an online format. One barrier for participating in CBT was the stigma, is what Sturdinger found. And this is the method that he used to reduce the stigma and privacy support concern. Privacy and confidentiality concerns, I apologize. ICT would also alleviate some of the burden of the financial difficulties, as it typically does not cost as much as an individual session of CBT would. There has also been growing support using the online format. Rowe et al. Found that there was very little difference in internet-based CBT and face-to-face CBT when treating adolescents and children. Sturdinger et al. Also conducted an evaluation of the effectiveness of a Danish version of ICBT, which was called Chilled Out online, and it was developed at the Center for Emotional Health in Australia. Results in that study indicated 40% of participants post-study no longer had symptoms of anxiety in comparison to the 60% that were on the waiting list. And treatment was effectively maintained, at the 3 to 12 month follow-up period. Next is psychoeducational programs. Psychoeducational programs provide information regarding illness or diagnosis, general information regarding healthy living, problem solving, ways to identify stressors, and management of stress symptoms. Morgado et al. Psychoeducational programs can also provide information that is easily shared with family members so that the family and the patient have a better understanding of their diagnosis, in addition to how they can best assist the client in treatment. And researchers have reiterated the importance of developing a psychoeducational program, as it reduces levels of anxiety and also provides the patient, if they are open to it, another format of support through their family. School-based interventions play an important role in the lives of children and adolescents, as many spend majority of their lives at school. In addition, they have contact and build supportive relationships with school staff and other trusted adults. School-based interventions are designed to work independently from the classroom and school counselors. The purpose of a school-based intervention is to reduce or prevent the concerns regarding mental health and problem behavior such as depression, anxiety, bullying, and factors from at home. A previous systematic review of school-based interventions designed to treat depression and anxiety found that it was effective on symptoms, and it remained effective for 12 months during the follow-up period. School-based intervention program is something that we are familiar with. This is something that I utilize in my own practice. Music therapy is our next treatment modality. Research on treatment modality today is largely centered around the use of as it said, music therapy and therapeutic work, as it is a way to form an amicable personality in adults. It is defined as a process in which mental health professionals help the client reach in better overall health. And that's from Belsic et al. 2022. The practices of music therapy can be separated into three categories, which are A, active, which involves the creation of music. The second is receptive, which involves listening to music. And C would be active and receptive, which is a combination of creating music and also listening to it. Researchers Machnick et al. 2021 examined anxiety in adolescents post psychocorrection through the use of music therapy as a form of intervention. The purpose of the study was to examine the effects of music therapy as a form of reducing symptoms of anxiety in adolescents. Results indicated that music therapy was effective when used in practice with other mental health services, such as a counselor or a psychologist. Reductions in symptoms can be accomplished by learning the necessary skills to help when anxiety is high and also rebuilding the self-esteem. So learning the skills necessary when the counselor is not there and anxiety arises. Next is biblical discussion. And the first verse comes from Philippians 4, chapter 4, verses 6 through 7. Be anxious for nothing, but in everything by prayer and supplication with thanksgiving, let your requests be known to God, and the peace of God, which surpasses all understanding, will guard your heart and minds through Jesus Christ. And that's from the Holy Bible, 1973. I also found other biblical discussions that I felt fit together perfectly to sum up today's current research. Have I not commanded you? Be strong and courageous. Do not be afraid. Do not be discouraged, for the Lord your God will be with you wherever you go. So do not fear, for I am with you. Do not be dismayed, for I am your God. I will strengthen you and help you. I will uphold you with my righteous hand. For the Spirit God gave us does not make us timid, but gives us power, love, and self-discipline. Therefore, do not worry about tomorrow. Tomorrow will worry about itself. Each day has enough trouble of its own. I felt that these passages were very powerful when put together. We should not worry about what may come or what is happening, as God ultimately has all the power and is there to strengthen us, and He will not put us through more than we can bear. Next is gaps and limitations of the current research. So the first limitation includes the ability to confirm causal relationships between variables due to the cross-sectional design used by Yang et al. 2019. The next is the limited amount of research on pharmacotherapeutic treatment options for adolescents with anxiety disorder. The third is limited number of participants due to the baseline and follow-up. They see Brain 2018 seen a drastic decline in their numbers from the follow-up period in comparison to the baseline. The next is found in Rowe et al. There was a lack of control group or pre-interview to establish a baseline of symptoms of anxiety in order to compare how much the participants had improved. Nelson et al. 2023 found that there was a limited data on the long-term effects of their treatment in their research project. In addition, current research had a heavy reliance on self-reported data, which could have impacted the way in which people answered or reported data. So research proposal. The purpose of the study is to examine symptoms of anxiety disorder in adolescents and find the most effective treatment modality when used in co-occurrence with school-based interventions. Researchers hypothesize that adolescents with anxiety symptoms who receive school-based interventions will experience a reduction in symptoms and an improvement in social support, perceived control, and academic outcomes in comparison to those in the control group. The research questions are: what was the most effective treatment intervention when used in conjunction with school-based interventions for reducing anxiety? And the last research question is: are there any changes in symptoms of anxiety when comparing the adolescent's baseline to their post-treatment outcomes? So to begin, participants will include adolescents ages 8 to 18. An average of 90 participants, along with their families, will be chosen. All participants will be recruited from a nearby school system. I'm sorry, an average of 90 adolescents, along with their families, will participate. Participants will be asked to identify as male or female and provide their ages. And participants in this study will reside in the state of Virginia. Participants will be recruited from the nearby school system in Virginia. Referrals will come mostly from teachers, school counselors, administration, school psychologists, local community service boards, and other mental health agencies. We will also accept referrals from parents. Participants must have an onset of anxiety symptoms or been diagnosed by a mental professional with anxiety prior to the study. Consent to participate will be obtained from the family and the child, ESENT, and an agreement for services will be also obtained by both. In addition, an initial interview will be conducted with both the participant and their families to establish a baseline of the participant's symptoms. So the survey will consist of 43 questions, 2 demographic, and 41 that will examine anxiety. The first demographic question will be multiple choice in format and ask participants to identify as male, female, or other. The second demographic, it will be a short answer format, and participants will be asked to write their age. And then the 41 item inventory will be used to examine their anxiety, and that inventory will be the screen for children anxiety screen for child anxiety related emotional disorders, also known as SCARED. This model assesses for 5 factors, which are panic, somatic, also generalized anxiety, separation anxiety, social phobias, school phobias, which are in a parallel to the DSM-5 classifications for anxiety disorder. This SCARED will use a 3-point Likert scale and range from 0, not true, or hardly ever true, which is 0, not true, or hardly ever, to true, very true, or often. This is the Biram et al. 1999, and they designed the study. Examples of this study are: when I feel frightened, it is hard for me to breathe. I get stomach aches at school. I have nightmares about that something bad is going to happen to my parents. I am afraid of having anxiety attacks or panic attacks. I worry that something bad might happen to my parents. And this is a child version. The parent or guardian version is: my child is afraid of having anxiety or panic attacks. My child is worried about something bad will happen to his or her parent. My child is a worrier. My child often gets frightened for no reason. And this is just, of course, examples of the 41 question item. So as I mentioned, it will be a 3-point Likert scale. And Sorry, give me one moment. Um, this screening will be used as a pre and post test. The inventory will be given during the initial interview session in order to get a baseline of the symptoms. This scared inventory that we chose is typically utilized with children from 8 to 18. And the child and the parent will complete this assessment. It takes approximately 10 minutes for both to complete. It can be utilized with a clinician or a psychiatrist, and it needs to be completed by both the parent and the child. Biram et al. Established a strong retest reliability of the SCARED over a 5 to 15-week period with 88 children and 86 parents, which is one of the reasons why we chose our participant, the number for our participants of being 90. So procedures. Participants will be recruited using a electronic flyer sent out by the school board office to all staff at the middle, high, and elementary level. The elementary level will focus primarily on the second through fifth grade. It'll also be sent to directors of community service board, counseling agencies, and other facilities who provide mental health support to be shared with their employees. In addition, individuals will be asked to make a referral for students experiencing anxiety via the flyer, which will have a link to a Google form where the referrals can be sent. Only participants who have an onset of symptoms of anxiety prior to this study or a diagnosis will be included in the study. Once consent is obtained from the families, an initial interview will be scheduled and the pretest will also be given. A total of 15 sessions will be conducted. Sessions will be conducted by approximately 9 professionals. And by professional, I mean licensed clinicians. Sessions will take place after school, utilizing the local middle school as it is a central location for all the other elementary schools and is central to the area in which we are using. I'm sorry. The total number of clinicians we have estimated is 10. As these individuals have to also be recruited within the local population. Each clinician will have a caseload of approximately 9 in hopes of reducing the heavy caseload and decreasing the likelihood of burnout. The study will include quantitative data. The statistical analysis will be 2 levels, which are the pre and post tests of the SCARE to determine if there is correlation in statistical significance. Participants will be split up in 2 groups, the treatment group and the control. Treatment group will be further broken down into 5 subgroups, with all clinicians utilizing a different treatment modality from the ones that I previously mentioned. And the other 5 clinicians will utilize a person-centered approach. So therefore, this is between subject study. The scared score for panic disorder, there has to be a score of 7. And the numbers that are scored are 1, 6, 9, 12, 15, 18, 19, 22, 24, 27, 30, 34, and 38. If these questions all have a combined score of 7, it may indicate panic disorder. For anxiety disorder, the numbers being scored are 5, 7, 14, 21, 23, 28, 33, 35, 37. And in order to obtain a diagnosis of generalized anxiety, you must have a score of 9. For separation anxiety, this inventory looks at questions 4, 8, 13, 16, 20, 25, 29, 31. and there must be a score obtained of 5 to indicate social phobic disorder. And lastly, for significant school avoidance symptoms, they looked at numbers 2, 11, 17, and 36, and there must have been a score of 3 to indicate symptoms of school avoidance. A factorial design analysis will be performed using SPSS 28.0.0.0. The alpha level, of course, will be 0.05. At the end of the study, participants were thanked for their participation, also giving the information to the institute's counseling center should issues arrive post-survey. So gaps and limitations in regards to the proposed study, inability to participate due to lack of adequate care for younger siblings. This is something that may occur if there's not family support in order to take the children or any childcare after the time of 5 o'clock. The potential for clinician burnout, decline in the number of participants as the study continues. As we recognize, this is a 15-week long study. The numbers may drop off. Having both the parent and child reporting data may result in higher prevalence rates of symptoms than having one person. Difficulties with transportation, as this study is being conducted in a rural area. And also the proposed study has a heavy reliance on self-reported data, and children may answer in a way that they feel like their parent would not be upset about or would be more accepted by the parent, and parents may have a reluctancy to also report information due to the child being in the same environment. So future research is needed in the study of other exercises and potentially useful treatment modalities such as art therapy, and how it can apply to various age groups. Research is also needed to examine the long-term effects of the pandemic on the adolescent's mental health and overall well-being under the conditions of being social distance. Further investigation is also needed to examine anxiety and depression in adulthood and the lasting effects of it. Next is the need for an examination on gender differences in parents and adolescents. And lastly is the need to understand why reduction in anxiety symptoms was not similarly translated into the improvement of overall life improvement and the interference. Conclusion. Anxiety has an onset that typically occurs. I apologize, there's noise in the background. Typically occurring during childhood. Anxiety is one of the most common disorders for both children and adults. If left untreated, it can lead to catastrophic events such as suicidal behavior, disruptive behavior, underachievement in education, suicide, substance abuse, poor overall health, and economic difficulties later in adulthood. These are my references. And this concludes my presentation.